Hello, everyone. My name is Sandeep. I'm an interventional cardiologist at the University of Chicago Medicine. I'm also one of the associate editors for JSCAI. I have the privilege of moderating this conversation today. I'm joined by some esteemed colleagues who will help us walk through a couple of very important papers that was just recently published in JSCAI. I'm joined by Dr. Yousif Ahmad from the Yale School of Medicine, Dr. Samir Kapadia from Cleveland Clinic, and Dr. Ingrid Hsiung, who was at Cleveland Clinic and is now at the Baylor College of Medicine. Welcome, everyone.
Thank you.
I think we'll get started with the main paper that we're discussing, which is looking at TAVR in patients at a high risk of coronary obstruction. Dr. Ahmad, you were the first author on this paper that was recently published in JSCAI, and so maybe you can have the opportunity to walk us through some of the high points of the study if you want to share your slides.
Okay, thank you very much, for the opportunity to discuss our paper and for the invitation. Presenting this on behalf of all co-authors. As way of brief background, we all know coronary obstruction is relatively rare, but is a life-threatening complication of TAVR. And there's not an awful lot of published data available about coronary obstruction, risk of coronary obstruction, and how it might impact procedural planning. We wanted to look a little bit in detail at a previous registry, which had been published, and to look at how valve choice may be implicated in risk of coronary obstruction. And sort of the headline finding, which we will go back to a little bit later, is that in patients who were deemed at high risk for coronary obstruction, who had some form of coronary protection strategy, those who were treated with self-expanding valves had higher risk profiles, both anatomically and clinically, as compared to patients with balloon expandable valves. And that's really what the main thrust in terms of the results of our paper. As I said, this is a multi-center registry. The main results of the corporate TAVR registry were published previously, and it's worth just briefly, reminding people the main registry, which was previously published, showed that as compared to a strategy of wiring only, the strategy of preemptive stenting seemed to reduce the risk of coronary obstruction and improve clinical outcomes. We wanted to look a little bit more in detail, again, have detailed CT analysis of each case. It's worth acknowledging this was performed at each participating center rather than at a core lab. And we looked at clinical outcomes at 3 years. And in this study particularly, we looked at the valve type or the valve choice. There were 236 patients from 19 centers. It was a reasonable mix, 57% roughly treated with balloon expandable valves, the remainder with self-expanding. And as I say, there were inherent differences in the clinical and anatomical profile of patients treated with each valve type. And we think this is the main message of the paper and what we really wanted to emphasize. So the first thing to look at is, valve-in-valve procedures. And you can see almost twice the rate of valve-in-valve procedures in self-expanding valves, 70% of the cases were valve-in-valve procedures. The balloon expandable cases around, just under 40% were valve-in-valve cases. And then if you look at the CT scan, all of these conventional parameters that we use to try and denote or predict risk of coronary obstruction, the height of the coronary ostia, the width of the sinuses, all of those were, numerically against the self-expanding valves, by which we mean the coronary heights were lower and the sinuses were narrower, and that was consistent. And if you look at some other, CT parameters that have been known to predict potential risk of coronary obstruction, we again see the self-expanding valves had a much lower valve to coronary distance, the average of 2.8 versus 3.9. And if you use a valve to coronary distance of 4, which has been, previously felt to predict risk of coronary obstruction, again, many more patients treated with self-expanding valves fulfilled that parameter. As a result of this higher baseline risk, patients treated with self-expanding valves had greater rates of coronary occlusion, and this seemed to lead to adverse clinical outcomes, including all cardiac death and all-cause mortality. But we want to emphasize that really, we're not suggesting that it's the valve type that is causing adverse events. It's more that patients treated with the self-expanding valves were the highest risk anatomical and clinical phenotypes. And as I say, these were frequently valve-in-valve procedures. The coronary heights were lower, the sinuses were narrower, and the VTC distance was smaller. We can touch on this in discussion, potential reasons why people might want to choose a self-expanding valve in these high-risk phenotype cases. One is perhaps the ability to recapture, and the other is self-expanding valves with supraannular design, maybe giving you better hemodynamics and lower gradients, which may take on even more importance in patients being treated for valve-in-valve when gradients are going to be high. We should acknowledge some limitations for our study. This was, of course, an observational study. There was no randomization involved. There isn't direct data on which factors influence valve choice. We're making inferences based on the CT data and the clinical data and the valve platform that was used. But we can't tell you exactly what caused particular operators to choose valves in certain scenarios. High risk of coronary obstruction was left, made by the clinical treating teams. There was no predefined definition for patients at high risk of coronary obstruction. So all of our CT data sort of post hoc. And as I mentioned, that CT analysis was done at each center, experienced high volume centers, but there was no centralized call-out analysis. And our paper doesn't give any insights to leaflet laceration or other techniques to reduce the risk of coronary occlusion aside from wiring or stenting.
Thanks so much for summarizing. Samir, you have a question or comment?
Yeah, first I wanted to just just for the audience to summarize that how many patients actually had the coronary obstruction and what really were the outcomes. So this is an important part to summarize in the native and the native as well as the valve-in-valve procedure, because these are two very separate, as you can imagine. The native valve versus valve-in-valve are two fairly distinct kind of patient populations that you encounter in this particular situation. So do you have an idea that this was true for both the native and the valve-in-valve procedures, or just for the?
Yeah, it appeared to be honestly true for both the native and the valve-in-valve procedures. The rates of definite coronary occlusion in the index trial were 4 delayed coronary occlusions, which occurred, I think, predominantly in valve-in-valve procedures. You're right.
And it's, I would imagine that it was difficult to gather this many patients, to the point I think that Dr. Kapadia is touching upon. It's a relatively low frequency event, absent these very high risk anatomical predictors, and 19 centers put together 236 patients. One question I had is, beyond the obvious points and, the most important points that you touched upon, including favorable hemodynamics and recapturability, why a self-expanding valve in valve-in-valve and low VTC? Any other considerations that perhaps drove this decision? Anything that could be inferred from the data, recognizing the inherent limitations of the data set?
Unfortunately, difficult to infer because we don't have any direct data saying an operator made X decision for Y reason. So we can't, we have to acknowledge that we are, speculating somewhat. The main reasons, we would speculate were, the ones that you've already touched on, that, a large proportion of these patients are having valve-in-valve procedures. And we know that the post gradients are typically high when you do TAVR for a valve-in-valve procedure. And that supraannular design, giving lower gradients and better hemodynamics, might be desired. So that's probably the main reason, number one. The second reason is potentially the other one you touched on, is recapturability. So if an operator is worried about coronary occlusion, the ability to not fully release the valve and recapture it and then try again, it is potentially a benefit. And I think those are probably the two major reasons.
I think one other reason that you may want to consider is that familiarity with the valve, right? So when people are using, say, predominantly self-expanding valves or prominently balloon expandable valves, they feel more comfortable taking the risk of a high-risk patient with the valve that they are more used to using.
Yeah.
This is an important part to keep in mind, because I encounter it all the time when people call and say that which valve do you use, and if I say this or that, they say, okay, no, I'm so used to this. Can I just use this? You think it's going to be a problem? So this is not an uncommon, uncommon emotion for interventionalists, that they want to use something that they're more familiar with. So this may be one of the things that drives sometimes the decision making, especially in the high risk patient population.
It can be in a high risk case. Yeah, exactly.
So, yeah, the other important question, so at least for me to understand, is that, as you know, the self-expanding and supraannular design makes the coronary access somewhat difficult. So if you get in trouble, it makes it more difficult. And just to give you an example, that our eighth case that we did of TAVR in 2007 had a coronary occlusion. And when there are two cases before us that passed away, one in Vancouver and one in Rouen, with Alan Cribier and Dr. Webb. We had studied them, autopsy, and we found that the leaflet was occluding it. So this was a new news at that time. We didn't know how to measure or anything, the coronary height. So we put a valve, and the patient had a cardiac arrest. So we are doing CPR, and we knew that this could happen. So we put the guide catheter, used the wrong end of the wire, the back side of the wire, and poked in the leaflet, and then wired the coronaries and stented it. And we put the patient on tandem heart, because that time we had planned tandem heart, believe it or not. And this particular patient had a TFO. Patient survived. 4 years later, she was alive. We did a CT scan. We had put 2 Texas stents, kissing, because short left main. And we wrote it up. And that time we analyzed the entire thing to say that it was mainly the height of the coronary, the sinus, the calcium, and the coronary is right in the middle. So all these things are, and it's so dramatic when this happens. It's as you know, it's bad news when the coronary closes. And when the coronary is so close, delayed is also a problem. And that is more common with the self-expanding valve than a balloon expandable valve, because it continues to press on the coronaries. And especially when you give protamine, or when you reverse the anticoagulation, after a while, patient gets into this kind of a trouble. So it is a dramatic complication, and prevention is better. I personally prefer to use a balloon expandable valve, because it's shorter frame and it's easier to access the coronaries. So this is my personal preference. And I understand that the compromise would be the hemodynamics for supraannular design. And these days, of course, some basilica procedure we do, but that is also for valve in valve. Sometimes it's tricky depending on where the valve is oriented to the coronary.
So Samir, you made a lot of great points there, and I want to come back to one of them, but let me ask Yousif another question here. I was reading this paper, I was sort of struck by the overall percentage of 3-year mortality was quite high, almost 22%, 21.6% with self-expanding, 3.7% with balloon expandable. On the other hand, delayed coronary obstruction, either definite or probable, was about 12% for self-expanding, 2% for balloon expandable. So to what do we ascribe that difference between a high rate of delayed coronary obstruction, but an even higher mortality in the self-expanding cohort in particular? Is it just related to comorbidities, do you think?
I think probably most likely. This, as you alluded to earlier, this was a pretty difficult registry to run. And cases began being accumulated in the early, 2010, 2011. So if you think about the patients that we were treating with TAVR at that time, they were the older, sicker, frailer patients. And if we look at, every single occurrence of death. We have documented causes for most of them, and the patients tend to be in their late 80s. Some of them were sudden death, some of them were heart failure. So I think that it's just a sick population. It was more typical of the TAVR population in the early 2010, 2011, when we were treating high risk or inoperable patients. If you add on top of that the fact that a lot of these patients were valve in valve, again, sicker hearts, previously had stenotomy. So I think that probably explains the high all-cause mortality.
Samir, I'd like to come back to something that you mentioned, a really important point. When are you persuaded? Let me ask you the flip. You prefer balloon expandable, and I think that we're all loath to put in 20 millimeter balloon expandable prostheses in a surgical prosthesis. You know what you're going to get in terms of gradient. When are you persuaded? When do you feel like you're really obligated, risk notwithstanding, to use a self-expanding prosthesis for valve in valve? What are your sort of clinical considerations that sway you in that direction?
So if the coronary is not a problem, then obviously for hemodynamics, and if the patient does not require another valve in valve, so like if the patient is 70-year-old, then I still sometimes prefer a balloon expandable valve, because there is a chance that in their lifetime they require another valve. But if they are 85 and they require a valve in valve, then I think self-expanding valve makes sense if coronary is not an issue. If the coronary is an issue, and if I'm going to use basilica or something like that, I still prefer to use the balloon expandable valve and compromise the hemodynamics to some extent, rather than to use a self-expanding valve, because it is trickier to access the coronaries. And even if there is no acute occlusion at the time, but even if there's a delayed problem, it makes the life much more difficult and unnecessarily exciting. So I think the easier solution to the problem is a balloon expandable valve. Maybe Ingrid can tell us something more, that when we looked at our data, to say that how many times we had to put a stent and things like that.
Yeah, I was just going to say that's a great transition, I think, to another really important paper that was just published in JSCAI. Ingrid, do you want to talk a little bit about the Cleveland Clinic experience that you published earlier this year?
Yeah, so we took a look at all patients who underwent TAVR at our institution between 2014 and 2019, and we found that out of over 1,900 patients, 41 of them ultimately underwent left main protection with wire, balloon, or stent placed preemptively in the left coronary artery. Out of these, actually, there were only 8 that required stent deployment. So this was roughly 1 in 4 patients that needed stent deployment. These were patients that were very high risk by criteria of kind of traditional risk factors, like left main height, ostium was short, sinus of Valsalva was small, valve in valve patients as well. Our outcomes, kind of like what Dr. Ahmad was saying, he was saying that maybe in 2010 there were a lot of sicker patients. Our age or our year range was between 2014 to 2019. So, maybe we didn't capture those first patients here. But at least for us, 30-day MACE was excellent, 0%. 1 year, we had 0 patients that required repeat catheter-based interventions. And the patients that did die, 4 of them, at median follow-up of 350 days, they were non-cardiac death, things like pneumonia, things like cancer, hospice, etc. It may be due to either smaller sample size, we had 40 patients rather than 200 patients, or due to the fact that all of our patients were balloon expandable valve, not self-expanding, that we had these relatively better outcomes. But what do you like to add to that, Dr. Kapadia?
No, I think it is perfect and a good this thing. So few things to remember, that the cause of death is tricky. So even if the 4 patients died because of so-called non-cardiac things, you can never be so sure, right? Because you can have pneumonia because you have a heart failure and things. Of course, in our data set, we are fairly granular and we studied it and all that, and we didn't. But it is always, whenever we have to put a stent in somebody's coronary behind a valve, it is tricky. It is not a situation where you will not follow them very closely. You will want to keep an eye on them. So I would not say the take-home message for me is to say that, okay, 1 in 4 patient requires, but when the other ones that we didn't put a valve, we didn't put a stent, we did IVs, we did coronary, we made sure that these people do not require a stent. And it is many times, it is a borderline call. And these borderline calls, we follow the patient at 1 month, 6 months. We may sometimes do a coronary CTA before we discharge them. So there are a lot of different kinds of ways to make sure that we are not ignoring the potential disaster. Because remember, the left main occlusion is many times does not give you a chance, second chance. It is a tough one. So just keep that in mind. And I personally think that if you're going to protect the coronary, if it is very high risk, then put a guide liner, put a stent such that you can remove the stent if you don't need it. So many of these patients, if you protect with the stent can be behind the frame and it may not come out. So I usually use a guide and a guide liner and then put a stent, take the guide liner back so that when you deploy the balloon, the guide liner doesn't jam into the left main. And then if we want to take it out, we can take it out. Or these days, my preference is to put a wire and a balloon to protect the left main. And then once you deploy the stent, cross with a separate guide and a wire from the stent into the left main, and then put a stent. So stent is not behind the valve, but rather coming straight into the valve. And most of the time, you are able to do that, if you protect it with a balloon and a wire. So the left main will not be completely closed, but you will be able to wire and put a stent so you can push the leaflet down. And that, I think, is a better strategy these days that we use rather than putting a stent directly behind a chimney style stent.
Samir, how do you decide when not to put a stent? Let's say you've protected in some form and you've deployed the valve. What criteria do you...
Criteria, so very important. So what I like to do, there are 2-3 things. So one is in a LAO cranial projection, I like to do an injection with the guide or whatever we have to see the leaflet, because most of the time we see the filling defect of the leaflet and the left main coronary artery. So you see a white line and you see the coronary artery. You can tell how far or close it is, number one. But this is not a good measure because we never know that this part of the leaflet is in front of the coronary artery or this part, because it's a 2-dimensional picture. So if the coronary artery is posterior, then you are on the back side or the shorter part of the leaflet, and typically they do okay. So if the STJ is wide, then you will be able to get the blood, not necessarily through that side, but in the back side. So I like to do an cranial view, which is an end-on view, to see the valve from the top and inject the dye and see if there is space around the valve that would let the blood go through to the left main. And then finally, if I'm not going to stent it, and if it looks borderline, then I like to do intravascular ultrasound to make sure that, so again, intravascular ultrasound is impossible to do from the back. So you would have to take out the big delivery sheet, put a guide catheter, leave the wire in place, rewire it, and then do an intravascular ultrasound to see that where the leaflet is in relation to to be 100% sure. I myself feel comfortable if the STJ is large. So if the valve is not touching the STJ, and if the left main is not completely occluded by the leaflet, typically there is enough flow and it will not occlude it because you will have blood flow coming from. But if the valve is touching the STJ and the sinus is trapped, I feel uncomfortable because sometimes the blood will clot there when you give protamine, and then you can close the cord.
I just want to remind the viewers that the analysis included almost 2,000 patients, 1,925 patients in your analysis from the Cleveland Clinic. Only 2.1% of these patients actually had left main protection. So we're talking about a very small proportion of the overall TAVR patients. I do have a question. What predicted the need for left main intervention was a larger valve, a larger annular circumference, a lower ratio of STJ to prosthesis diameter, and a longer left coronary cusp. Are there any other sort of clinical call-outs for folks that are watching this video? Do you give any special consideration for non-obstructive but quantifiable disease at the left main ostium, even if some of those other metrics aren't in the mix? Any other clinical considerations that would persuade you to protect?
I think the most common thing that I see that people, when the friends say that they didn't expect this to close and it closed, and can you tell that something we did wrong? Some people call. Most common thing that people miss, in my opinion, is the long left leaflet. So the coronary is high. Let's say coronary, they measure 12 millimeters, but the leaflet was 14 millimeters. And that they didn't take into consideration. So, and the small STJ. So if the STJ is small and the leaflet is long compared to the height, you want to be very careful. So this is what we also found in our data, but I think that is, in my experience from France, this is the most common reason why people have a trouble in unexpectedly, because all the companies and all these softwares alert you when it's less than 10. They say that, hey, left main is low, left main is low, left main is low. But if it is 10 or 12, they say no big deal. But 10 and 12 can be a big deal if the leaflet is 14, and that does happen.
We see that very commonly in bicuspid cases. They get these long leaflets, and it's good to have your antenna up. If you're doing bicuspid case, a lot of calcium in the leaflet, that the risk of coronary occlusion can be high despite the conventional left main height that they give you being adequate. So I think it's a useful metric for people to be aware of.
Excellent.
Well, great. I think we covered a lot of ground here, and we're right up at time. So I'll give Dr. Ahmad and Dr. Hsiung the last word here. Any final thoughts?
No, I mean, as I say, great discussion. Thank you for the ability to come here and discuss the findings. And we really wanted to emphasize in the manuscript that we're not saying that the use of one valve or another is going to cause adverse outcomes. We're trying to understand why people choose certain valves in certain scenarios and what are the clinical and anatomical phenotypes. And I think what Samir said is very important, that our nature is to use what we're most comfortable with, and that manifests the most in the highest risk cases we do. I think rightly so. You don't want to introduce a new variable into the mix when you're doing something that is exceptionally high risk.
Right. I would echo what Dr. Ahmad said. Thank you so much for the opportunity, to speak about these manuscripts. And just again, as TAVR is kind of expanding, it's more and more important to come up with really criteria that all of us can use to determine, how best we can protect these high-risk patients.
Wonderful. Well, thank you, all of you, for joining us today and for a terrific discussion. And thanks everyone for doing it.